So HRT and cardiovascular system was another issue, and in that that was another reason why the study for the combined CE MPA arm was stopped during the WHI study, is because there was an increase in coronary artery disease, coronary heart disease by 24%. However, in women who started on therapy within 10 years of menopause, there was a risk reduction of 11%. So basically, this came, all of these other studies that came on, or the follow-up studies to the WHI itself, showed that the timing hypothesis referred to the theory that starting HRT closer to the time of menopause transition, the cardiovascular events is seen much less, and it is not an issue. So following that, there has been many other studies. I don't know if anybody really wants to hear all of these studies, but let's say that there was, just to name them, the Danish osteoporosis studies, which evaluated composite endpoints as far as the cardiovascular system, and that was positive towards use of hormones. The HERS study, the 7-year early versus late intervention trial, or ELITE study. Again, everything is about the timing of when the timing hypothesis and when to start those hormones, and that was also in the Finnish nationwide death registry. And then, of course, there were multiple meta-analyses about the subject, all of which basically determined that the cause of mortality, that there was a decrease or neutral risk of congenital heart disease when estrogen and or progesterone, depending on the type, was used. As far as strokes, stroke incidence increased in both arms of the WHI trials. However, studies with oral estradiol were conflicted, showing a similar stroke risk, and the incidence of fatal stroke was unchanged. HRT and the risk of VTE or venous thromboembolism, comprised of transdermal, that basically deep venous thrombosis and pulmonary embolism was increased by twofold in the WHI study, but the transdermal estradiol does not confer the same thromboembolic events. And the ESTER study from France showed an overall risk of 0.9 for a blood clot, basically a decreased risk. So, right now, contemporarily, or what we believe, that each woman must be assessed in the context of her unique presentation and concerns for physical findings, and whether she's looking for relief of her vasomotor symptoms, and of course the most effective being estrogen, and basically even in the absence of significant vasomotor symptom, HRT is a good option for healthy women within 10 years of menopause. Even though the most commonly used estrogen in the past was CEE, or conjugated estrogen, equine estrogen, oral estradiol and transdermal estradiol each have a variety of doses, can be titrated to achieve treatment goals, and could be less risky. And the choice of progesterone is important, and MPA being, or metoxyprogesterone acetate, being the worst. Dihydrogesterone, nortestosterone, and drospirenone, all of them have better data than the medroxyprogesterone acetate. And once you stop those treatments, the symptoms come back with a vengeance. Of course, I wanted to put the video of Sam from Sex and the City going to Dubai, and she arrives to the custom in Dubai, and they're taking away her hormones, and then she goes into a crazy fit. It's like, hormones, I'm gonna grow my beard and I'm gonna be a monster. Give me my hormones. So you had to talk to, isn't there a prince or somebody I can talk to? Anyway, so contrast between outcomes with various progesterone. Obviously, there's different kinds of progesterones. The only role for progesterone in menopausal therapy was against the endometrial hyperplasia and the endometrial cancer. All clinical trial, most observational studies have evaluated multiple progesterones or progestins, and have found important difference in the metabolic effects and the disease outcome. The PEPI trial found that micronized progesterone taken sequentially and MPA taken either daily or sequentially provided effective endometrial protection. Obviously, in both the WHI trial and the HERS study, the CEE-based regimens, including CEE/medroxyprogesterone acetate, reduced incident type 2 diabetes. A meta-analysis of 107 HRT randomized controlled trials provides strong evidence that HRT statistically significantly reduces new onset diabetes. And also, the most clinically important difference between the progesterone is, as we mentioned, about the breast tissue. So MPA being the worst. The other ones were not as bad. Also, as far as the use of transdermal estradiol with micronized progesterone rather than CEE with MPA did not significantly increase cell proliferation. So that was better for breast cancer, basically.